Good afternoon, students. I am Dr. Anusha. Today we will discuss about retina. In the previous classes, glaucoma is completed. I think you have all performed well in the exam, internal assessment. So today we will start with retina. Today we are going to deal with the macroscopic anatomy of retina, microscopic anatomy and structure, and the blood supply of retina, and various vascular occlusions of retina. So, just to recapitulate, how many layers are there in the eyeball? There are 3 layers. Outer one is the fibrous layer, that is sclera, and the middle vascular layer, choroid, and the inner neural layer is the retina. So, retina is a thin, transparent, and delicate membrane, which is the innermost part of the eyeball. It extends from optic disc to the ora serrata, and grossly it can be divided into 2 parts, posterior pole and the peripheral retina, with the help of an equator, which is an imaginary line joining the exit of the vortex veins. So what is the color of the retina? It is purplish red in color because of the underlying vascular choroid and also because of the presence of visual purple rhodopsin. Coming to this is the picture showing retina. Here you can see this is the outer fibrous layer sclera, and this red one is the choroid vascular layer, and inner neural layer. This yellow one is the retina. It extends from optic disc to the ora serrata. On macro examination, you have 2 important structures in the posterior pole. One is optic nerve head or optic disc, and other important structure is macula lutea. So what is optic nerve head? I think you have all learned about optic disc in glaucoma. Again, a bit small revision of optic nerve head. It is the site where the ganglion cell axons, they accumulate and exit the eye through the optic nerve. So what is the shape of the optic disc? It is vertically oval and it is pink in color, and the size, horizontal diameter is 1.5 to 1.7 mm and vertical diameter is 1.8 mm. It has a pale central area called the physiological cup. The normal size of the optic cup is 0.3 mm. So the cup disc ratio is 0.4. So this is a picture showing optic disc, or also known as optic nerve head, because it is the starting point of the optic nerve. It is called optic nerve head. So this pale central area is called the optic cup, and the surrounding pinkish healthy structure is the neuroretinal rim. In optic disc, all the layers of the retina terminate except for the nerve fiber layer and internal limiting membrane. As the photoreceptors are absent in the optic disc, it casts a physiological blind spot in the visual field. So what is this neuroretinal rim? This is it contains the nerve fiber layer and ganglion cells. So what is the thickness of the neuroretinal rim? It is more broad inferiorly, followed by superior, nasal and temporal. Next, coming to macula lutea. This is also known as yellow spot. Why is it yellow in color? Because of the presence of xanthophyll pigments and also the thick RPE, which masquerades or occludes the shining vascular choroid to be seen better. So it casts a yellow color to the macula. So what is the diameter of the macula? It is about 5.5 mm in diameter, and it is temporal to the optic disc. In the center of the macula, there is a part known as fovea centralis, which is about 1.5 mm in diameter and is the most sensitive part of the retina. Why? Because it contains only cones, and cones are responsible for visual acuity in the daylight. So it has best visual acuity. And in the center of the fovea, there is a foveola. So this is a representation of the macula. If we consider this as a macula of 5.5 mm in diameter, in the center it has fovea. This is 1.5 mm in diameter. In the center of the fovea, we have foveola. And in the foveola, there is a central depressed shining pit called the umbo. So This is the total posterior pole of the retina. Here we have the optic disc with the central cup from which the retinal vessels emanate into the retina from the optic nerve head. And this pinkish part is the neuroretinal rim. So this is the posterior pole with the optic disc, and another structure is macula lutea. Macula lutea, also known as yellow spot, with the center fovea containing foveola and umbo. So surrounding fovea there is parafovea and perifovea. So what is the location of foveola? It is 4 mm temporal to the optic disc and about 0.8 mm below the horizontal raphe. Next, coming to peripheral retina. So I already mentioned retina is divided into posterior pole and peripheral retina by equator. So in the posterior pole we have macula and optic disc. And now peripheral retina is categorized into 4 parts: near periphery, mid periphery, far periphery, and ora serrata. So near periphery means it is about 1.5 mm around the macula. Mid periphery means 3 mm around the near periphery. Far periphery means it is about 9 to 10 mm from the optic disc on the temporal side and 16 mm on the nasal side. And ora serrata is the most peripheral part where the retina ends. It has serrated edge, and from there it continues into choroid. And at the ora serrata, the retina is firmly attached to the vitreous base. So this is a diagrammatic representation of the peripheral retina. So 1.5 mm around the macula you have near periphery, and surrounding 3 mm is the mid periphery. And from 8 to 10 mm nasal to the disc is the far periphery. So here to west part is the far periphery, and this is 16 mm is the far periphery. And the most peripheral part is the ora serrata, where the retina continues into the choroid. Coming to microscopic structure of the retina. So retina has 10 layers. From inside to out, we have internal limiting membrane, nerve fiber layer, ganglion cell layer, inner plexiform layer, inner nuclear layer, outer plexiform layer, outer nuclear layer, external limiting membrane, layer of rods and cones, and retinal pigment epithelium. So memorizing these 10 layers is very difficult. So it can be remembered in the mnemonic as in new generation, it is only ophthalmologists examine the layers of retina. I, internal limiting membrane. Nerve fiber layer. G for ganglion cell layer. And this is inner plexiform, inner nuclear, outer plexiform, outer nuclear, external limiting membrane, layer of rods and cones, and RPE. So these are the 10 layers of retina. This is a picture showing the microscopic structure of the retina. I will come back to this picture later. So first we will go to each layer of the retina in detail. So first, outermost layer is the retinal pigment epithelium. So it is the outermost layer of retina, and it is firmly attached to the choroid Bruch's membrane and loosely attached to the layer of rods and cones. So there is a potential space between RPE and rods and cones. So what is RPE made up of? It is made up of a single layer of hexagonal cells with pigment in them. So what is the main function of RPE? It prevents reflection of light and provides the metabolic nutrients to neural retina. Next layer is layer of rods and cone cells. These are the photoreceptors, and they transform light energy into nerve impulses. So there are two kinds of photoreceptors. One is rod cells and another one is cone cells. So what do rod cells do? They help in night vision, also known as scotopic vision. So they contain a photosensitive substance known as rhodopsin, useful for night vision. Next, coming to cone cells. They contain a photosensitive pigment called iodopsin, and they are useful for night bright vision or daylight vision. That is called photopic vision. So cone cells, they are about 6.5 million, and rod cells, they are about 120 million in the retina. So these are the rod structure of the rod cell, and this is the cone cell. Detailed description of the structure is not required for you. In the layer of the rods and cones, we have only the outer segments. Up to this part only, it is present in the layer of rods and cones. This part will come in the nuclear layer. Next, coming to external limiting membrane. It is a fenestrating membrane which extends from the ora serrata to the optic disc, and through this external limiting membrane, the process of rods and cones pass. So these processes, these fibers, outer rod fibers, they pass from the layer of rods and cones into the outer nuclear layer. So this fenestrated membrane is called external limiting membrane. So next layer is the outer nuclear layer. I already mentioned this contains the nuclei of both rods as well as cones. Next, coming to outer plexiform layer. Outer plexiform layer is made up of synapses between the rod and cone spirules with the dendrites of the bipolar cells. Next, coming to inner nuclear layer. It consists of bipolar cells, horizontal cells, amacrine cells, and Muller cells, as well as central retinal vessels and glial cells. So this layer, it is absent at the fovea. And another important thing is bipolar cells, they act as first order neurons. Next layer is the inner plexiform layer. It consists of synapses between bipolar cells and the dendrites of the ganglion cell. And this layer is also absent at the fovea. So next layer is ganglion cell layer. This consists of cell bodies of ganglion cells and nuclei of the ganglion cells. So photoreceptors are rods and cones. First order neurons are bipolar cells and second order neurons are ganglion cells. So there are various types of ganglion cells: W, X and Y, P and M ganglion cells, off-center and on-center ganglion cells, monosynaptic and polysynaptic cells. So monosynaptic cell means here one ganglion cell synapses with one bipolar cell. Whereas polysynaptic cell means many bipolar cells synapse with a single ganglion cell. So monosynaptic is present in the central retina, whereas polysynaptic cells are present in the peripheral retina. Next, coming to nerve fiber layer. It consists of unmyelinated axons of ganglion cells which converge at the optic nerve head. The thickness is about 0.5 to 2 micrometers, and the thickness decreases from optic disc to the ora serrata. And the fibers show definite arrangement, that is, superior arcuate fibers, inferior arcuate fibers are present temporal to the optic disc, whereas superior radiating and inferior radiating fibers are present nasal to the optic disc. I think this arrangement of the nerve fibers is dealt with you in the glaucoma section. Next is the innermost layer, that is the internal limiting membrane. It separates retina from vitreous, and it is formed by union of the terminal expansions of the Muller cells. So these are the 10 layers of the retina. Outermost is RPE. So it contains single layer of hexagonal cells. Next is layer of rods and cones, consisting of the outer and inner segments of the rods and cones. Next is external limiting membrane, that is a fenestrated membrane through which the rod spirules and the cone pedicles pass. Next is outer nuclear layer. So nuclei of rods and cones are present here. And next, outer plexiform layer, that is the layer containing synapses between rods and cones with the dendrites of the bipolar cells. Next is inner nuclear layer. Here this nuclear layer contains bipolar cells, horizontal cells, amacrine cells, and Muller cells. Next is inner plexiform layer, that is synapses between the bipolar cells and axons of bipolar cells and dendrites of the ganglion cell. Next comes the ganglion cell layer. So it contains ganglion cell bodies and fibers. Next, coming to nerve fiber layer, that is axons of the ganglion cell layer. And next most innermost layer is the internal limiting membrane. So these are the 10 layers of retina. Next, coming to how is the arrangement of these 10 layers in the fovea. We previously I mentioned that inner layers of retina, that is inner nuclear layer, inner plexiform layer, all these layers are absent in the fovea. You can see that here fovea contains only RPE layer and more abundance of cones, and you can see that outer plexiform layer, it is obliquely arranged. This is called Henle's layer, and all the other layers of retina are absent, and you can see only internal limiting membrane. So because of more abundance of cones, it has better visual acuity with minimum threshold. Next, coming to functional division of the retina. Retina can be divided into temporal retina and nasal retina. So nasal retina, the nerves which arise from the nasal retina, they pass through the optic nerve, and after crossing through the optic nerve, they get crossed in the optic chiasma to reach into the contralateral optic tract, and then they reach the contralateral geniculate body. Whereas in temporal retina, there is no deposition. Those arise from the temporal retina, they go through the optic nerve. They do not cross in the optic chiasma, and they go to the ipsilateral optic tract and ipsilateral geniculate body. So next, coming to the blood supply. So there are 4 outer layers and 6 inner layers. So outer 4 layers, they are supplied by choroidal vessels, that is anterior and posterior ciliary arteries. Whereas the inner 6 layers, they are supplied by central retinal artery, which is a branch of ophthalmic artery. So what is important in the central retinal artery is it is an end artery. So there are no anastomosis between each other. After emerging from the optic nerve head, the central retinal artery divides into superior and inferior trunk. And again, each trunk, it divides into 2 branches, temporal as well as nasal. So central retinal artery is a branch of ophthalmic artery, and it divides into superior and inferior trunk. And each trunk again divides into 2 branches. So as I already mentioned, these are end arteries, and there are no anastomosis at the ora cerebri. So this is the central retinal artery. It divides into 2 trunks, superior and inferior. Later again, this superior divides into temporal and nasal. This also divides into temporal and nasal. Next, coming to retinal veins. These veins, they follow the pattern of the retinal arteries. So central retinal vein, here you can see there is superior as well as inferior retinal vein, and again nasal and temporal, nasal and temporal. All these then drain into the single central retinal vein, which drains into cavernous sinus directly. So this completes the microscopic anatomy of the retina and blood supply. So macroscopically, there are, what is the color of retina? It is purplish red in color, divided into 2 parts: posterior port, peripheral retina, and posterior pole optic disc and macula. In the macula, we have fovea, fovea, and optic disc, optic cup, and neuroretinal unit. So that is posterior pole. And in the peripheral retina, we have near periphery, mid periphery, far periphery, and ora serrata. So that is the macroscopic appearance of the retina on fundus examination. So how do you see this fundus examination? It is done with the help of indirect ophthalmoscopy, either with the usage of either 90D lens or 78D lens or 20D plus 20D lens. Microscopically, we have 10 layers. In new generation, it is only ophthalmologists examine the layers of retina. So that is the mnemonic for memorizing the 10 layers of the retina. Coming to blood supply, outer 4 layers are supplied by choroidal circulation, that is anterior ciliary artery and posterior ciliary artery. Inner 6 layers are supplied by central retinal artery. So that completes the anatomy of retina. Coming to congenital anomalies, these are not very important for you. Just I have mentioned some important main 2 anomalies. One is the coloboma of the optic disc. This I have discussed previously in the coloboma of choroid. It is caused due to failure of the closure of embryonic fissure. There are of 2 types, minor or fully developed coloboma. So this is a picture showing coloboma. Here there is defect in the inferior closure of the optic disc, embryonic fissure, and similarly here also there is coloboma, and the disc is pushed superiorly. Next is drusils. These are intrapapillary refractile bodies. They lie deep beneath the optic disc and they emerge out by the early teens. In children, they present as pseudo-papilledema. Papilledema means edema of the disc margin. There are other congenital disc anomalies like hypoplastic optic disc, myelinated nerve fibers or metilated nerve fibers, and persistent hypoplastic primary vitreous. So these are all not very important for you, so I have not discussed them. Next, coming to diseases of the retina. Broadly, this can be grouped into various types like vascular retinopathies, vascular diseases of the retina, inflammations of the retina, degeneration of retina, detachment of retina, hereditary dystrophies, and congenital abnormalities. So today we deal with vascular disorders of the retina. So what are the various vascular disorders of the retina? These are caused by obstruction, which is either complete or partial, permanent or temporary, and it can affect both the retinal arteries as well as retinal veins. So when it affects the artery, it can be either central retinal artery occlusion or branched retinal artery occlusion or cilioretinal artery. So what is cilioretinal artery? Sometimes the macula can be supplied by a cilioretinal artery, which is a branch of the choroidal circulation, and it does not emerge from the central retinal artery. Coming to the venous occlusions, they can be either central retinal vein occlusion, hemiretinal vein occlusion, or branched retinal vein occlusion. So first we'll deal with retinal artery occlusions. So it is more common in patients with hypertension, diabetes, and arteriosclerosis, and also in patients with other cardiovascular diseases. The obstruction of the central artery, it causes the entire retina becomes ischemic. If the peripheral branch is involved, then localized ischemia will be present. Coming to etiology. So there are various factors which influence the occurrence of retinal artery occlusions. So the main important thing is emboli. There are three types of emboli. One is cholesterol emboli, calcific emboli, and fibrinoplatelet emboli. Cholesterol emboli, here you can see these are orange in color and refractile, and they are seen at the bifurcation of the retinal vessels. Coming to calcific emboli, they are white in color, and the origin of this emboli is from cardiac valves. Similarly, fibrinoplatelet emboli, they are more dull white in color, and these are also arising from the cardiac valves. More common cause of retinal artery occlusions is emboli. Later, we have atherosclerotic related thrombus. And next, other causes is retinal arteritis with obliteration. So these are seen in diseases like giant cell arteritis as well as polyarteritis nodosa, SLE. All these cases there is arteritis. So inflammation of the artery is present, leading to emboli or thrombus formation. Next is angiospasm. This is also a very rare cause of retinal artery occlusion. Raised intraocular pressure. So it is seen in conditions where raised IOP, it causes pressure on the artery, leading to occlusion of the vessels. Like in RD surgery, that is retinal detachment surgery, we place a scleral buckle. Encirclage operation is done. So when the scleral buckle is tight, it leads to raised IOP and causes pressure on the central retinal artery. Similarly, other causes are thrombophilic disorders like polycythemia or any deficiencies in coagulation disorders. All these can lead to increased coagulation of the blood, leading to occlusion of the artery. Other rare disorders are migraine, thrombocytopenia, hemoglobinopathies, polycythemia, and use of OCPs. So, in artery occlusion, we have central retinal artery and branched retinal artery occlusion as ciliary retinal artery occlusion. So, first we will deal with central retinal artery occlusion. So, it is more common when compared to BRAO. It accounts for about 65% of the causes of retinal artery occlusion. So, here the central retinal artery is occluded at the level of lamina fibrosa. What is the main symptom with which the patient comes? The patient complains of sudden onset of loss of vision. With also history of recurrent obscurations of vision. Like transient ischemic attacks, there is transient obscurations of vision. This is called amaurosis fugans because there are small emboli. When they cause occlusion, there will be transient loss of vision. Later, these small emboli they get discharged, leading to restoration of vision. So the patient complains of transient attacks lasting for about 30 seconds, and again the patient regains the vision. So this condition is called amaurosis fugans. And what are the signs? So what we see in such patients, visual acuity will be markedly reduced, ranging from 3/60 to sometimes no BL can also be present. And how does the pupil? The direct pupillary reflex is absent and RAPD is positive. What is RAPD? It is relative afferent pupillary defect. That is when we show light into the normal eye, there will be constriction of the pupil in the opposite eye. But when light is shown in this eye, there is no constriction of the pupil. That is, it dilates. So when shown into the normal eye, the abnormal eye pupil will constrict. Whereas when shown into this eye, because there is no supply from the optic nerve, as there is ischemia of the retina, there will not be any constriction of the pupil when shown into the abnormal eye. That is called relative afferent pupillary defect. In fundus examination, we see that the arteries are reduced to thread-like and they become very thin and attenuated. The smaller arteries, they are almost invisible. And initially, the veins, they appear normal, and in the late stages, they become contracted. The retina becomes opaque and milky white, especially around the disc. And there is appearance of a cherry red spot in the fovea centralis. What is this cherry red spot? It is a 2-mark question for you. The cherry red spot is appearance of a reflex in the fovea. This is actually a normal appearing retina and is observed in contrast to the surrounding milky edematous retina. So why do you see the reflex present in the fovea? Because the underlying vascular choroid can be seen clearly from the central fovea. As already mentioned, fovea is very thin and the surrounding retina is edematous. So the underlying vascular choroid near the fovea is clearly seen in contrast to the surrounding milky white retinal edema. So we see a cherry red spot. If the obstruction is not complete, then the flow can restore within few days. In late stages, up to 4 to 6 weeks after, generally the retina becomes atrophic and the opacification reduces, and there can be cattle drug segmentation of the blood in the retinal veins, and later there is consecutive optic atrophy and the optic disc becomes pale. So this is a initial stage of central retinal artery occlusion. Here you can see the arteries, they are narrowed when compared to the veins, and the retina is milky white and edematous. So this is cherry red spot. That is normal foveal reflex, which we see is highlighted more because of the surrounding macular edema and retinal edema. It stands in contrast to the surrounding white edema. This is because fovea is thin here and the underlying vascular choroid can be seen clearly. So this cherry red spot is important diagnostic feature of central retinal artery occlusion. There are other disorders also where cherry red spot is visualized. That is in case of gangliosidosis like Tay-Sachs disease, Niemann-Pick's disease, spondylolipoidosis. All these cases we see cherry red spot. And this is late stages of central retinal artery occlusion. Here you can see in veins there is segmentation of the blood. So that is called cattle truck appearance. That is on the wet mud. If we move the cattle truck, there will be signs of the wheel left behind, track of the wheel on the mud. Similarly, you can see tracking of the blood into segments in the veins. So this is called cattle truck appearance. This is an important PG question for you. In some conditions, in spite of central retinal artery occlusion, vision will be retained. So what we should suspect in such cases? We must think that macula is supplied by central cilioretinal artery or macular branch of the central retinal artery might be given off proximal to the occlusion. So this is ciliary retinal artery spare. So rest of the retina becomes milky white in color because of the central retinal artery occlusion. But here macula is spared. You can see the normal pinkish color of the macula. This is because macula is supplied by ciliary retinal artery. In some cases, only ciliary retinal artery becomes occluded and the remaining part of the retina is normal. In such cases, you have to see that ciliary retinal artery occlusion is present. So next coming to branched retinal artery occlusion. So here the area supplied by the branch is affected. So edema is restricted only to the area supplied by that branch. So corresponding visual field defect will be present. Sector shaped defect in the visual field will be the main complaint of the patient. Vision will be less only when the branch supplies the macula gets involved. Otherwise, vision is retained in branched retinal artery occlusion. So, what is the treatment for artery occlusion? Central retinal artery occlusion. The retinal tissue can survive ischemia only for a period of 90 to 100 minutes. So, any treatment we give to a patient with central retinal artery occlusion, immediate treatment is very important because if delayed treatment, by that already retinal tissue becomes ischemic and the changes are irreversible and later retina goes into atrophy. So this first 1 to 3 hours is very important in a patient with central retinal artery occlusion. So what is the treatment we give for a patient with CRA? First we have to do immediate lowering of the IOP so that by lowering of the IOP we can aid in the perfusion of the central retinal artery. So how do we lower the IOP? Either we can do ocular massage with the help of digital ocular massage or pinky horn on ball. Anything can be done and paracentesis should also be done. What do you mean by paracentesis? That is, we have to tap the anterior chamber with the help of a needle. Or you can use other IOP lowering drugs like acetazolamide and mannitol. Next, we have to use carbogen mixture. So what is this carbogen mixture? It is a mixture of 5% carbon dioxide and 95% oxygen. So inhalation of this carbogen, it leads to relieving of the angiospasm so that any amount of blood circulation can be restored to the retina. And usage of vasodilators like nitroglycerin as well as isosorbic dinitrate can also be used. In some patients, retrobulbar injection of acetylcholine may also be helpful as a mode of vasodilation. Other modes of therapy are fibrinolytic therapy, that is streptokinase injection and tissue plasminogen activator. All these sometimes may play a role. In patients with giant cell arteritis, we can use IV steroids. Laser photodisruption of the embolus can also be done in certain cases. Coming to workup of the systemic conditions, I already mentioned here retinal artery occlusions are more common in patients with cardiac diseases, diabetes and hypertension. So when a patient comes with CRA, generally we have to check for cardiac status of the patient. So we must order routine carotid Doppler as well as cardiac echogram. Coming to the complications of retinal artery occlusions. One of the delayed complications is neovascular glaucoma. It occurs in about 2 to 6%. Next, coming to retinal vein occlusion. So retinal vein occlusion, the main etiology, it can be categorized into 3. In the vein, within the vein wall, and outside the vein. So inside the vein causes increased coagulability, as in polycythemia, use of OCP, severe dehydration. All these lead to coagulation of the blood inside the veins. And the conditions which are responsible for occlusions in the vein wall, that is vascular diseases in old people such as diabetes, hypertension and arteriosclerosis. Similarly, infective periphlebitis, as after typhoid, influenza, Eales disease, sarcoidosis, SLE, all these can cause inflammation of the vein wall leading to increased coagulation of the blood. Next, coming to conditions outside the vein. the pressure on the central retinal vein due to local ocular conditions like orbital cellulitis or any tumors. All these cause pressure on the central retinal vein leading to occlusion. So, as already mentioned, retinal vein occlusions, they are of three types: central retinal vein occlusion, hemiretinal vein occlusion, and branched retinal vein occlusion. Coming to central retinal vein occlusion. So, it is mainly of broadly divided into two types: non-ischemic CRVO and ischemic CRVO. So, central retinal vein occlusion is more common in elderly age group, and non-ischemic CRVO accounts for about 60 to 70% of the cases of CRVO. So the initial symptom of non-ischemic CRVO is vague unilateral loss of vision. And on examination, in the early stages, we see mild venous congestion and tortuosity with flame-shaped hemorrhages. They are more marked in the periphery. Disc edema can be present. Macular edema is generally absent. In the late stages, we see sheathing of the veins along with the occurrence of collaterals, and sometimes neovascularization can be present. Retinal hemorrhages, they get partially absorbed in the late stages. Macula shows chronic cystoid macular edema in moderate cases, and it is normal in mild cases. So this is a picture showing non-ischemic CRVO. So what I have mentioned, the early signs are venous dilatation and tortuosity. You see the lumen of the vein is much wider, and there is tortuosity of the veins. They are more wavy, and hemorrhages. So all these flame-shaped hemorrhages, these are called superficial hemorrhages, and they are more in the periphery when compared to the posterior. And other feature is disc edema. Here you can see the margins of the disc both superiorly, nasally, and slight inferiorly. There is blurring of the disc margin. So this is called disc edema. In the late stages, we can see sheathing of the veins. In this picture, it is not seen. Sheathing of the veins is present, and collaterals are present, and hemorrhages, they get partially absorbed. So next, coming to the other variety of CRVO, that is ischemic CRVO. It is seen in elderly people in contrast to non-ischemic. Non-ischemic is seen in age group of 20 to 40, whereas ischemic is seen in more than 40 to 50 age group. And diabetes, hypertension, these are more risk factors for ischemic CRVO. So the patient presents with acute, sudden, complete loss of vision in one eye. And obscuration of the central retinal vein is generally behind the lamina cribrosa, where the artery and vein, they both share a common adventitious sheath. So when they are both in the same sheath, because of age, there is atherosclerosis of the artery. So this thickened artery, it causes pressure on the central retinal vein, leading to occlusion of the central retinal vein. So it is more common behind the lamina cribrosa in elderly individuals. So what are the signs you see? In early stages, similar to non-ischemic, here you can see there is venous congestion and tortuosity, but there is more massive engorgement and tortuosity of the retinal veins in comparison to non-ischemic CRVO. And you can see the retinal hemorrhages, they are massive. This appearance is called splash tomato appearance. And you can see numerous soft exudates. So what are the soft exudates? These are the infarcts of the nerve fiber layer. So these are seen as cotton wool spots. And there is also disc edema and macula. It is full of hemorrhages and edema is present. In late signs, you see sheathing around the veins, collaterals are present, and neovascularization is present in the disc and elsewhere. This neovascularization is also known as neovascular, it leads to neovascular glaucoma after 3 months of onset of CRVO. So this is called 90-day glaucoma. And in the macula, you see permanent pigmentary changes and cystoid macular edema. So this is a picture showing ischemic CRVO. So here you can see there is disc edema. You cannot see the outline of the margins of the optic disc, and veins, there is more congestion and tortuosity. And hemorrhages, they are more massive when compared to non-ischemic CRVO. And another feature of ischemic CRVO is occurrence of soft exudates. So this white fluffy Lesions are called as soft exudates or cotton wool spots. These signify retinal nerve fiber layer infarcts. In macula, you can see hemorrhages as well as edema of the macular region. So these are early features of ischemic CRVO. In the late features similar to non-ischemic CRVO, we see sheathing as well as collaterals, but neovascularization of the disc and elsewhere of the retina is more common in ischemic CRVO. And occurrence of NVG is also more common in ischemic CRVO. So how do you differentiate between ischemic and non-ischemic CRVO? There is presence of RAPD in ischemic CRVO, and also visual field defects are present in ischemic CRVO. And we do electroretinogram, there is reduced amplitude of the B wave. So these three are important differentiating features of non-ischemic and ischemic CRVO. Coming to complications, as already mentioned, neovascular glaucoma, it occurs in about 50% of the cases within 3 months. So this is called 90-day glaucoma. And in some cases, vitreous hemorrhage can be present and proliferative retinopathy is also present. And important thing is non-ischemic CRVO, in about 15% of the cases, it converts into ischemic CRVO within 3 months. Next, coming to branched retinal vein occlusion. It can occur either at the disc margin. So, if it occurs at the disc margin, either superior whole retina is involved. So, that is called hemiretinal vein occlusion or inferior hemiretinal vein occlusion. If main branch, which is away from the disc, at the AV crossings, it leads to quadrantic occlusion. That is either supratemporal, supranasal, infratemporal, infranasal. This is called quadrantic occlusion. Whereas totally superior is involved, it is called hemi occlusion. Or another type of branched retinal vein occlusion is macular or peripheral BRVO. So what are the signs? Here the edema and hemorrhages, they are limited to confined to the area where the vein is occluded. So vision is affected only when the macula is involved. Secondary glaucoma is rare in case of BRVO. But if macula is involved, chronic macular edema can be present and neovascularization may also occur in some cases. So this is a picture showing supratemporal BRVO, hemorrhages and soft exudates with macular edema. The inferior part is normal and supranasal part is also normal. So this is called quadrantic occlusion. Here the occlusion is at the level of arteriovenous crossings in the supratemporal quadrant. When compared to infratemporal quadrant, supratemporal quadrant is more commonly involved. So this is in late stages of supratemporal BRVO. In the late stages, you see all these hemorrhages, they are resolved. And you can see collaterals, that is connection between the vessels. So these are collaterals, and this is hard exudates. You see the difference between hard exudates and soft exudates. These are fluffy and the borders are wavy, whereas in hard exudates, they are discrete and they are small, multiple in number. So these are hard exudates, these are collaterals. So this is long-standing picture of supratemporal BRVO. This is macular, small macular BRVO. Only the branch supplying the branch draining the macula is involved. So hemorrhages and soft exudates, they are confined only to the macular region. And this is inferior hemispheric occlusion. So both temporal as well as nasal part of the inferior retina is involved. So this is hemiretinal venous occlusion. These are the types of branched retinal vein occlusion. So how do we manage a case of venous occlusion? So first we have to completely evaluate the patient clinically. Ocular examination, visual acuity is important because what treatment is to be given is based on the visual acuity. If it is better than 618, then we go for certain treatment. If it is less than 618, then we go for certain treatment. So visual assessment is very important. Similarly, IOP should be measured because raised IOP, like primary open-angle glaucoma, is an important risk factor for venous occlusions. And also, if a patient comes with late onset The late stages of central retinal vein occlusion, the patient may present with MVG. In certain that cases, IOP will be raised. So IOP recording is important. And gonioscopy should be done for examination of neovascularization in the angle. And fundus examination to differentiate between whether it is ischemic or non-ischemic or branched retinal vein occlusion. So we have to differentiate. So fundus examination is thoroughly evaluation is needed. And what are the ocular investigations we do? Goldman perimetry. So what is perimetry? It is used for assessment of the visual field. So as already said, in ischemic CRVO there will be visual field defects, whereas in non-ischemic visual field defects will not be seen. So perimetry is essential for distinguishing between non-ischemic and ischemic CRVO. Next, other investigation is fundus fluorescein angiography. So what is this fundus fluorescein angiography? Anywhere angiography means we have to see how the pattern of blood flow is present in the vessels. So with the fundus fluorescein angiography, we see there is blockage of the vessels, and we can also see there is exudation as well as hemorrhages. All these block fluorescences present in the ischemic CRVO. And next, coming to OCT. What is OCT? It is optical coherence tomography. Here you can identify whether there is macular edema or macular edema is absent. Next, coming to systemic examination. In the systemic examination, there are many systemic risk factors as I already mentioned. So we have to rule out hypertension, diabetes, cardiovascular diseases, and also hypercoagulable states like polycythemia and thalassemia, sickling hemoglobinopathies, and also sarcoidosis. All these must be evaluated and thoroughly investigated before proceeding for the treatment. So next, coming to treatment. So how do you treat a case of retinal vein occlusion? So first, when the patient comes, we have to look for the vision. If vision is better than 680, then we have to observe the patient carefully. We have to regularly follow up the patient every 1 to 2 months for any occurrence of complication or to monitor the signs of resolution. For the patients with vision which is less than 680, so the main cause of drop in the vision is involvement of macula, when there is macular edema or when there is retinal neovascularization. So in such cases, we have to treat the patient. So what are the various treatment modalities available? For macular edema, we can either give intravitreal anti-VEGFs. VEGF means vascular endothelial growth factor. So the various anti-VEGFs you know are ranibizumab and bevacizumab. These can be given intravitreally, but they help in resolution of macular edema, but the action is not long lasting and repeated injections are necessary within 1 to 2 months. So 2 monthly or 3 monthly, we have to evaluate the patient doing OCT and FFA, and then repeated injections must be administered. Other drugs which are used for macular edema are intravitreal triamcinolone. So it is a steroid and it also helps in resolving macular edema. For this also, repeated injections of every month are required, 1 to 2 months. So alternative to triamcinolone, we can implant a dexamethasone implant inside the vitreous. That is called Ozurdex. So instead of giving the repeated monthly injections of triamcinolone, Ozurdex implant, it can postpone the injection rate and it can last for up to 6 months. Next mode of therapy is laser therapy. So grid laser, it is used for persistent CMV in patients with PRVO. But in patients with CRVO and macular edema, we do not advise grid laser because we cannot differentiate from macular edema and macular ischemia. So it is better to avoid laser and go for intravitreal steroids or VEGF injection in patients with CRVO because it helps both for neovascularization control as well as macular edema. In patients with neovascularization of the angle, iris or retina, we have to go for PRP. It is not mandatory to give pan-retinal photocoagulation in patients with CRVO. As a prophylaxis, it is not useful. Only when patient develops with neovascularization, during the follow-up, then only we have to give PRP. It cannot be used as a prophylactic method, but in some patients where follow-up is not possible, we ask the patient to come routinely for follow-up after 1 month or 2 months, but the patient is not able to follow up and there is severe ischemia of more than 10 quadrupole spots are present or all the 4 quadrants are involved, then in such patients we can plan pan-retinal photocoagulation. And in patients with BRVO and neovascularization elsewhere, in the small quadrant, if we see neovascularization, then we can go for scatter laser. So these are the medical therapy and laser therapy. And next is surgical therapy. So what are the surgical therapies? You know, pars plana vitrectomy. This is indicated in patients with persistent vitreous hemorrhage or when there is fractional retinal detachment, epiretinal membrane, and neovascular glaucoma. And other surgical methods are we can go for glaucoma procedures like valve implantation, valves. All these can be done in patients with NDG. And also in some patients, they suggest phlebotomy. That is, we can go behind the globe and central retinal vein occlusion. Sheathotomy can also be done. Optic nerve sheath fenestration can be done so that it relieves the pressure on the central retinal vein. So that completes the vascular disorders of the retina. So we have discussed about central retinal artery occlusion, branched retinal artery occlusion, cilioretinal artery occlusion. And in the vein occlusions, we have dealt with central retinal vein, both ischemic, non-ischemic. So ischemic is also known as hemorrhagic retinopathy, and non-ischemic retinopathy is called, non-ischemic CRVO is called venous stasis retinopathy. So we have dealt with CRVO ischemic and non-ischemic, BRVO, hemiretinal vein occlusion, and various treatment modalities we have. So in today's topic, what all we have covered, the important questions for you are the microscopic structure of retina. It can't be an essay or 4 marks for you, but generally it is asked in the Viva. And central retinal artery occlusion treatment, retinal vein occlusion and treatment, they can be given as a 4 marks question, and cherry red spot is a 2 marks question for you. So this completes today's topic of retina, and in the next session I will deal with diabetic retinopathy. If time permits, I will complete hypertensive retinopathy in the next class. So if you have any doubts, you can ask. You are free to ask. If you are not clear in any point or I have rushed through any topic, then you can ask me so that I will repeat that particular topic again. If you have any doubts, you are free to ask. So is it clear to everyone? The lunchtime, I think everyone is almost hungry and waiting for the lunch, and they're not listening to the class also. No one is having any doubts to ask. Okay, then I'll take it granted that you all understood the anatomy of retina and vascular disorders of retina perfectly. So in the next class, we'll deal with diabetic retinopathy, and in the next class, in the starting 10 minutes, I'll ask you a few questions of anatomy and vascular disorders of retina. So be prepared on Wednesday. Okay, thank you.